So I start with this magic word, universal access. Everybody loves it, the international organization, and every person would like to live in a country with universal access to healthcare. But what do we mean by this? But generally, people mean simply, well, I will have a doctor next door and I will get free medicine, and there will be a hospital, public hospital with large open doors, and I can just walk in and that's it. We do have such systems in quite a lot of countries with huge populations. I don't quite know about India, but I know quite a lot of things about Brazil and Russia. These countries do have public healthcare systems where everybody can go like this, and they function partly without any health insurance, without any money. So it's just open doors. But there's a risk, because when I saw all these countries and they have all these wonderful public hospitals in Rio de Janeiro, and the bottom of every favela, there's a brand new hospital. My colleagues from university, they don't go to that hospital. They all have a private health insurance from their employer, from their university, or from if they work for the government, and they go to different hospitals. They see different doctors, and they seem to be all in very good health. So the risk with this idea of universal access, just open doors, is very often you will have two separate healthcare systems, what we call in German or in French, a two-class medical system. One for the poorer people and one for the people who have sort of middle class, upper middle class, and the upper class, and they don't use the same institutions. And from there you can guess that probably they don't get the same quality of care, these people. So this is the basic, for me, the basic issue in the concept of universal access. Does it also mean equity? Does it also mean equal treatment, the same good treatment with the same good technology for everybody? Because then you have a quite different problem of organization. It's not enough just to set up a few public providers of healthcare. Now, we had a little reading on access where it was already a little bit extended, the term, and it was explained you also need timely treatment. It means it's not enough to have just access. Let's say you have a cancer. If you're not treated in time, you will probably die. If you're treated very early, or the same is true for AIDS now, if you get medicine very early, a diagnosis very early, you can live with it. So timely treatment is part for me of universal access. It needs two conditions. There needs to be an accessible primary care system, because it's the general practitioner who does the surveillance of people, and he will see early enough that you have some illness, which, if it's not treated, becomes severe and maybe even a vital issue. So timely treatment is very, very important. And for this, you need primary care, not big hospitals at that first step. And you need rapid transportation systems for emergency. Imagine a man drops down in the street with a heart attack. If he's in the hospital with a very rapid warning system and transport, he will survive, and he will survive well. But if it's 3 or 4 or 5 or 6 hours or a day, he will get to a hospital just for dying. So timely treatment is part of universal access. Equal treatment, I said it already, and I would add, it includes gender. Equal treatment does not only mean that all the boys get good treatment and all the men, it also means that all the women and all the girls get good treatment. And this is not so in every country. What else does it need? Well, I would say what we call in Europe now patient-centered care. That means the care that is delivered in a region or in a country should be socially and individually adapted to the people. So there are different cultures, there are different ways of talking to people, different conceptions of health, and all this should be integrated in universal access, that you have a doctor who knows how to talk to you without making you suffer or feared. So then you have very material conditions. You need sufficient resources in terms of funding, money, manpower, and technology. Because if you want to care for everybody in the country in a timely way And in an equal way, with the same good treatment, you will need a lot of money, a lot of manpower, and a lot of technology. So where does it come from? Who will pay for this? You need a good geographical distribution of the services, so that in every part of the country, the services will be available. Of course, you cannot put a hospital into every village, but you can organize the networks that every ill person from every village will get in time to a hospital where he can be treated in good conditions. So it also needs coordinated networks between all the care levels. In my first lesson, I talked about primary care level, secondary care level, and tertiary care level. That's in terms of technology. Yeah? So there need to be networks between these levels in order to get timely treatment, equal treatment, and the right treatment. So it starts here with the GP, with the general practitioner. So far for the term, for this magic word, universal access. So there's much more behind than just open doors and free medicine. Now, we talked about different healthcare systems, types of healthcare systems, and how do they react towards the issue of universal access? Just to recall. It is universal by origin, so you don't need to add any universal access. People who have lived in Britain, they know it. You go and get an inscription in the National Health Service, and then you can go to any doctor, to any hospital, and you don't need to pay. This is the basis of a National Health Service. But there are problems. National health services are very well managed and controlled by the government. Regulation is very strong. They can limit the budget. They do limit the budget. They decide how many people will be recruited and how many hospitals will be built and the equipment will be renewed or not. It's according to these discussions at high government level. So if you then have everybody who has access to universal care, you may have problems with not enough means, and you have waiting lists. And Britain has always had waiting lists. They exported many patients to France for hip operations, for instance, because they had to wait 2 years in Britain, and in France they could have it immediately. So we made agreements between French hospitals and the National Health Service in Britain, and the people could come, and then the bill would be sent to Britain, to the National Health Service. So it was sometimes within the European Union, you can make these type of arrangements. Another problem of national healthcare systems and universal access is the care basket may be a bit limited. So there may be many things like glasses or hearing aids or things like this, or complicated operations which will not be done inside the National Health Service because it would cost too much money, or which will not be done for only for young people, not for old people, and things like this. So because these problems exist very often in national health systems, we have read it in the reading about Sweden, we have read it about England, and the whole literature tells you the same. They are very often private, supplementary private health insurances in these countries. So supplementary means they bring a supplement there where something is lacking. Many of these private health insurances are sponsored by your employer. He offers it, he can offer it to his employees or to his most important employees, for instance, and it allows you to jump the queue, to have less waiting time. You go to some other hospital, a private one where there's no waiting time. It's reserved for these private supplementary health insurances. Or you can see privately people from the National Health Service also. You may have a right to private hospital room or better and quicker medical procedures, more benefits like little things like glasses, hearing aids, or dental replacement. They may pay for alternative medicines like Chinese medicine or thermal cures. So you have these private health insurances which live as a supplementary thing besides the National Health Services to go around the problems for the people who can afford such a private health insurance. Because there's no option to leave the National Health Service. You will always pay your contribution, either to the National Health Service you pay, it's paid by the general taxes. You will continue to pay your taxes to the National Health Service even if you are always cared for by a private health insurance. So you will have somehow to pay twice. You cannot, there's no exit option from the National Health Service in Britain or in Sweden. The result of all this is universal access, understood in the way of national health services, has the risk of waiting lists or limited care basket, and the possibility for some people to have a supplementary issue to get out of this problem. And it is a sort of light version of a two-class system. A light version, not a heavy version. I am precise about this. So far for the national health system, it becomes more complicated with the social health insurance systems. I have to explain more things, 3 slides. Because the origin, if you remember, of social health insurances was some sort of solidarity between professional groups or between economic branches, and they had their health insurance for their members. So people were grouped, let's say inside Germany, by different groups who had different health insurances, and they were looking after these people, and the solidarity was within this group. So there were people then, of course, who were in no group because they didn't work, they were too old, or they were too ill, or they were peasants, didn't have such things. It came later. Domestics, or all sorts of groups who didn't have these institutions, they were then not covered at all. So this was managed in the way that in the interwar time, 2 world wars, and in the 50s and 60s, in these countries who have these social health insurances, they extended it to other groups to complete the universal access, to make it universal. And that was achieved more or less in most major European healthcare systems in the early 70s. But then we had an economic crisis, first oil crisis, and economy shrunk, taxes shrunk, contributions shrunk, and more people were ill because of stress and economic problems. So the health insurances, the social health insurances, they all had a problem with money. So they had to do something because the world had changed. Social changes, people got divorced, so there were women without health insurance. They used to be insured with their men, with their spouses. Unemployment, people who were unemployed over a certain longer time, they were not health insured anymore. Young people who couldn't find a job, students who were a little bit older already, studying too long, they didn't have a health insurance. So there were all sorts of problems because we had an economic slowdown. So the old model was some sort of breaking. So we found partial solutions, which were, we did something for the unemployed, we did something for the divorced people, we did something for the young people, for the students, and so on. And some countries did a very big change in those 70s, 80s. Italy and Spain, for instance, changed their healthcare system from a social health insurance system to a national health service, a decentralized one. So this somehow worked. From the 70s, 80s, early 90s, the thing works. But then came a new big change that was new technology, globalization, with competition with countries where wages were much lower. So the labor market was changing in Europe. And that made the same problem than the first economic slowdown, even worse for the health insurances, because they had less money coming in because the economy was slower, and they had more money running out because health expenditure was growing. It's always growing because of technological progress, because of chronic illness, where people don't die anymore because they have this or this illness. They become chronically ill and they need care for years and years. 30 years earlier, they died. So you have a natural growth of health expenditure, and then you have changing labor markets, and you have a problem you cannot manage anymore. And came a new ideology, neoliberalism, where we were told everything has to be private, then it's better. So we introduced a lot of reforms in our European social health insurance systems in the 90s and 20s. And it introduced cost sharing with more out-of-pocket payment, delisting medicines, so medicines that were paid by the health insurance before, if they were not really very important, they would not pay for them anymore. You would have to pay out of your pocket for these little things. All sorts of things were changing as what was because of cost control. Yeah, we had to save money. But the main thing changing was a changing labor market. Many people had not secure jobs anymore, and for that reason also were not health insured. All these fragile little jobs. So the result was, after the 70s, when we could do with partial solutions, in the 80s and 90s with the globalized world, there was a need for changes, bigger reforms, because we had a growing number of people who dropped out of the coverage of the social health insurance system. And the social health insurance had to do reforms for cost control, which made cost sharing bigger. So for poorer people, this was too a problem. So there was a big problem with universal access. So we had to maintain universal access, but how? So the policy responses, reforms in Europe, in these social health insurance countries, were very intelligent. It was not cutting the benefits like the neoliberals wanted and make private insurances. It was saying, well, we have to spend the money better. More efficient spending. We have to do more with the same money or even with less. So we have to reinforce regulation, or the government reinforced its control over all the social health insurances. They were much more independent before than they are now from the government. We had to do internal management reforms to manage the system better. And this is what we call the new public management. Here you have some details. Formerly, the healthcare system was more or less managed in bureaucratic ways, whether it was public or private, because the health insurances are big organizations. Now we try to manage them according to private enterprise management. So compress the labor force, take away everything that can be replaced by cheaper solutions. For instance, they checked in most countries all the medicines we prescribed and took out of the reimbursement list all those who were not proven really very efficient. All the medicines a little bit, they were thrown out of the basket. We restricted public works. For instance, cleaning in hospitals is not done anymore by hospital staff. It's done by private enterprises who work with cheaper labor. We had to reduce the hospital beds because we wanted to save money. Saving hospital beds means home care. So there are less nurses needed, less doctors needed. You can do all this by internet too. You don't need to travel to the home anymore. We did privatize a few things also in order to introduce competition between health insurances, for instance. Formerly, you could not enter any health insurance like this, social health insurance, because they were for certain groups. And now practically in all countries, I think they opened it. You can choose freely and they can't refuse you. I think I said it already. So they have to be managed very well. They have to have at their top a real manager, not a bureaucrat. So this we call regulated competition and regulated privatization, because there was always a government behind with its control, because we wanted to keep general access and a certain quality. The thing was not only saving money, it was spending the money better, get more out of the money, more quality and more people covered. So we reformed the hospitals and the care structures and reinforced patients' rights and patient power. In Europe, practically every hospital and every community, like the state, the town's government who has to do with medical structures, they will have some committee with the users of the healthcare system, and they will give their opinion and they will be consulted for all sorts of decisions. So choice for the users, I can choose my hospital, my health insurance, has also become a policy tool which reinforces the government control over the system. So they are policy partners now, the patients. So securing the social health insurance coverage for universal access, it meant in reality, I told you a few details, now I'll go over the details. You have to counteract the traditional imbalance of risks between different health insurance bodies. If you have health insurances for certain groups, you have always groups with a certain income in a certain health insurance, engineers, for instance, or house cleaners. So the house cleaners have more health risks and less life expectancy and less salary. So their health insurance is much poorer than the health insurance of engineers. I think this is easy to understand. So if you want to have universal coverage, you have to break this imbalance between the different health insurance organizations. Whether they're public or private is not really important. What is important that you break this imbalance. So you have to modernize the rules for affiliation. I said already, you can affiliate rather freely in those countries where you have the choice between different health insurances. In France, we don't have choice because we have only one, it's unified. And you have to reconsider the public-private health insurance mixed, which exists in some countries. Oh, sorry, it's always running away. So all these reforms are based on combining cost containment so that we will be in the future also capable of paying the growing health expenditure, because there's not only now in the past, there's also the future, and it will grow the health expenditure. So cost containment combined with modernization of the system and its organization and universal access. This was the idea of the reforms in Europe. It took a while to work on this because this is really a bit difficult. And the strategy is not yet finished. It's still going on. We have health reforms all the time now. But it is within this vision, cost containment, modernization also in terms of research and technology, to have a modern healthcare system, and universal access.